presented by Dr. Perrault from Montreal Heart. Welcome.
Thank you, sir. So hang on. Good morning, ladies and gentlemen. It's a privilege to present this talk on behalf of my co-authors. These are my disclosures. None are relevant to this presentation. So there's a great opportunity in cardiac surgery for patient engagement. About 80% of adults in the U.S. own a cell phone, and probably 105% of teenagers. So we know that patient engagement technology gives the opportunity to reduce perhaps cancellation, ER visits, and readmissions, and PROs, patient-reported outcomes, can help to evaluate the quality of care, but there is little research on this in cardiac surgery. So PRO, again, are health outcomes that are reported by patients, and they include quality of life, functional status, symptoms, protocol compliance, and patient experience. Now, we presented the initial experience from the Montreal Heart Institute at the STS in San Diego in January on over about 1,000 patients, the initial experience. However, we realized that there are limitations for the PRO collection data in cardiac surgery. Some only look at certain parts of the surgical continuum, some only single measures, and obviously single-center data collection does not permit a benchmarking of PROs. So we put together the three gentlemen you see here, or at least two of them, Dr. Engelman and Mischel, put together a collaborative project for ERAS centers looking on using the same application, Seamless ND, to benchmark these PROs to identify opportunities for improvement, leverage, obviously, the peer network to compare pathways and identify best practices, and use the platform ultimately to standardize delivery of best practices. And we think this is the first comprehensive study on cardiac PROs. So again, the goals were to collect standardized PROs across the continuum, so pre-op, in-hospital, and post-discharge, analyze a variety of PRO measurements or measures, and again, leverage the benchmarking dashboards to identify high performance, share best practices, and ultimately make improvements in all centers. So the application that's used, again, is Seamless ND. It was implemented at 3 cardiac centers. It's either a smartphone or tablet or computer-based. It actually guides the patient preoperatively in hospital and post-discharge, and it features reminders, education, progress tracking, and PRO surveys, and it enables the providers to monitor the patients and intervene sooner for patients that are at risk. So this is an initial experience from the Montreal Heart, more than 1,000 patients. 252 of them had completed a satisfaction survey, and 97% of them would recommend the app to other patients. Interestingly, 44% used the app to avoid one phone call to the hospital, and 27%, so almost one-third, used the app to avoid one visit to the hospital. Now, you can see here on a smaller sample at Baystate that patients using the application had a reduced length of stay of more than 1 day. The readmission rate was 21% down, and the discharge to SNF is 25% down. The data here from Prairie is even more spectacular. Same signal for decreased length of stay. The readmission rate dropped 45%, and the discharge to SNF 64%, so pretty impressive. So we ask ourselves, could we improve outcomes further by combining our PRO data sets, benchmarking performance, and try to inform changes to clinical care? So first of all, we did identify the common PROs already standardized, and then we standardized the remaining PROs and compliance measures. We set up dashboards on the Seamless ND platform to benchmark these PROs, and then we started conducting monthly meetings with surgery and nursing, nursing being more important than surgery in this kind of meeting, from all the 3 centers, and to try to benchmark performance and share the best practices. And then we started, and we're in the ongoing process of implementing best practices across all centers based on the high performers. So I'll give you just a couple of examples. This is compliance measures. Before, on early mobilization, it used to be different. Post-collaborative, we all have the same standardized measures. Same thing here for in-hospital. If you look at pain, nausea, or number of walks, breathing, it used to be slightly different, and now they're all standardized across the 3 centers. Same thing post-discharge. We looked at pain, compliance with the diet, the breathing exercises, walking. We set up only 1 set of measures. So between April 2017 and January 2019, close to 2,000 patients were enrolled and completed the full cardiac pathway. 72% of them activated the platform account, and we had more than 30,000 surveys that were completed. And this gives you an idea of the activation, either pre-op, post-discharge, and it wanes slightly and very slightly in the first 3 weeks after the operation, and we can talk about that later. So we started these calls in October 2018. Again, the 3 centers, we reviewed the multi-center PRO dashboards. We identify high versus low performers, invited the high performers to share best practices, and we began implementing new practices from high performers. And this is one of the benchmark dashboards that you can create. You can see here you have the 3 centers plus a mean, either for pain, anxiety, incentive, spirometer, or blood pressure. And based on those, we further analyzed to see why and who was doing better. And this was one of the examples, the post-op daily pain scores. Montreal Heart was identified as an high performer.
How convenient.
That's why I'm giving the talk. Okay, do never interrupt me again. MH, only Tom can. Okay, the MHI, so we're now sharing our pain protocols. Now I'm late. Okay.
You get an extra minute.
Okay, thank you. Thank you, Sinu. So the Prairie Heart was identified as a leader for in-hospital ambulation, and it's no small feat. I mean, actually, the patients at Prairie were walking 1 full day earlier than either centers, Baystate, or Montreal Heart, so we tried to emulate them. Well, one of the ways that we identified the problem is that the patients were reporting. We asked the patient, what made it hard for you to walk more walks every day? And 26% of them said there was not enough staff available to help them mobilize. And based on this observation, this enabled Prairie that shared their best practices, and Baystate implemented their system with a whiteboard tracking system and actually had a extraordinarily approved for walking in the ICU for these patients. The upcoming initiatives for collaborative efforts are, as I said before being interrupted, MHI sharing pain protocols and quality of life assessment tools. Again, Baystate is leading a cardiac prehab development, see whether this can have an impact and share it with the other centers. We're looking at also at other multi-center PRO data collection, opioid use, different quality of life questionnaires, and sleep quality. So we believe that based on this multi-site PRO data collection and benchmarking and collaborative quality improvement in cardiac surgery can become an effective means to improving surgical quality and patient safety by sharing best practices. We look further to expand PRO data collection and leverage actually the PRO compliance measures to validate ultimately the clinical benefits of each individual protocol element in the era of cardiac ERAS. Thank you for your attention.
Our discussant, Dr. Nguyen, hi there, yes?
I want to thank the association for the opportunity to discuss this presentation. I also want to thank Dr. Perrault for providing me the slides beforehand. In 2007, Steve Jobs walked into the Moscone Center in San Francisco and said, today, Apple's going to reinvent the phone. Before 2007, phones were bulky and really not that smart, but with the advent of the iPhone and other smartphones, we now do almost everything with our iPhones. We take pictures, listen to music, email colleagues, and we tweet #AATS 2019, to name a few. One thing that we haven't done well with the iPhone is use this technology to help patient care until now. Dr. Perrault and his colleagues used this technology from Seamless MD to collect patient-reported outcomes. Using the patient's phone, the authors found a decrease in length of stay, readmission, and discharge to SNF. This is the first time, to my knowledge, that technology on a phone can be used to collect patient data and improve patient care. The authors should be congratulated, and I suspect this is only the beginning. Dr. Perrault, I have 3 questions for you. First, could there be a selection bias where only the healthy patients respond while sick patients do not? Let's say a patient was admitted to the ICU in the nursing home and didn't have access to his or her phone. Certainly he or she would not be able to respond. Do you follow up on those patients that do not respond?
Well, it's an excellent question and obvious, and something that I did not state. In the initial Montreal Heart experience, only elective patients were approached. So, and we have to work to in-hospital and transfers from other hospitals. So definitely it's a different population than people that would come in much, much sicker. We're coming around for the sake, at least in the initial presentation or experience from Montreal Heart, of looking at pulling out the data from these patients. First, what is the difference between a patient that activates their account versus doesn't? Is there an age difference, a comorbidity difference, et cetera, and we'll be able to pull that. In this patient population, just crudely, the average age is about 68, so pretty run-of-the-mill cardiac surgery patient, but we need more granular detail. We need to know, and obviously, if we're, we need to know, do the people that answer the surveys are only the ones that do well, or are they complainers, or are they happy? We need to figure out their profile, because we want 100, it will never be possible, but 100% penetration, obviously.
Looking at your outcomes, did you stratify by procedure type? For example, an AVR, MVR CAB might have a longer recovery than a minimally invasive mitral valve repair. Do you stratify by procedure or risk profile of patients? And do all centers do a similar proportion of procedures and risk characteristics, which may explain improved outcomes at one center versus the other?
Obviously, the data and the characteristics for the patients, they need to be aligned. We need to see, we don't have that data yet. It's going to come in the manuscript because we need, again, to define the population. Overall, the number of the proportion of different procedures summarily look the same, but again, we need to be more granular to know exactly what we're talking about.
My last question is, what's the cost of implementing the program, and what would you estimate is the cost savings of having the program? Again, I would like to include, and thank you for a wonderful presentation, and thank the association for the opportunity to discuss this presentation.
All right,
You have time for one additional question.
Okay, well, thank you for that last question. The cost is, I think, is based on surgeons' practice, number of patients enrolled per year, et cetera. At the Montreal Heart, we were the initiators in cardiac surgery, so we had a package deal. I don't know how much and the fee structure in the US, but basically it's based on surgeons' practice and number of patients enrolled per year. And I think if we can prove, and that's what we're going to do, or we want to do ultimately, that we save hospital visits, readmission, then I think that we're rapidly going to show a great benefit of this technology. Which, one of the benefits that I did not show again, the patients feel more accompanied. They feel less anxiety. And this is, to your first point, this is enabling patients to have a better experience after heart surgery and even before. So I think it's significant. But we need data to support it.
Since we have such two esteemed surgeons at the microphones, maybe 2 really brief questions, and then we can...
Very quick practical question. Is there any provision in this app for patients to send you pictures or photographs of their incisions? Because I find that a lot of times, big reasons for readmissions are, wounds gone bad too late, and if you keep an eye early, you prevent a lot of disasters and significant deep infections eventually.
Good point. So the patients can do that. They can send any concerns. They can even, they give us suggestions. You should be asking this, you should be asking that. It's total patient input. It's very, very powerful.
But yes, you can take a self-picture of your incision, is the answer, yes.
That's what I said.
So Louis, thank you very much for your work from Winnipeg again. And I think you demonstrated one platform, and there are many platforms being developed for this space, which I think is really important, because I think it's important technology. One observation I have, and as we've worked through this ourselves, is when you see the engagement over time, so yes, people will start using it, but the durability waned after the first pint of discharge and down to like only 1/3 of those patients were doing it. How important is the content that's being put onto it being informed by patient, like for example, patient engagement panels to scale the content to what they would like? And two, the use of other caregivers or family members as part of that team to ensure that the compliance or the ongoing engagement is maintained to have the benefit longer term.
So that's a very good point. One of the differences we identified at the Montreal Heart is that caregivers of our populations are not involved, as if in the US they are. And so we have to look whether the rates of engagement after are greater. One interesting thing in our population, at least in Montreal, is that at 2 weeks, everybody, or 1 week, I guess they're too weak to answer or whatever. At 2 weeks, it goes back up, and then they do better, so they forget about the program. But we need to have all this insight, what motivates patient, and whether caregivers could enable to have a longer experience with the program.
One last little two cents I wanted to throw in is that we've used this to our benefit at Baystate, where since we've shown that at these other 2 institutions, they get their patients out of bed earlier. And we take that data and we bring it to the administrators and we go, we need more ambulation orderlies, we need more nurses, we need to get our patients to change their protocols and get out of bed. And it worked. I mean, it's instantaneous, because that graph showing that at Montreal and Prairie, they're out of bed a day or two before us, just blew them away. And it's real data and it's actionable. And that's the beauty of this technology. Thank you.
Great job. We've